Okay. I'm going to talk a little bit about adult spinal deformities and the kinds of things that I deal with and some of the other surgeons in our group deal with are major complex deformities of scoliosis and kyphosis. In many ways, the kinds of things that we do are not amenable to some of the microinvasive techniques that you just heard about, and these are very big procedures. I'd like to just go through the anatomy real fast so you understand some of the terms I'm going to deal with. Typically and normally, the spine is straight. Let's see if I can make this work. The spine is straight when looking straight at it, and it has three distinct curves when looking from the side. It's made up of a cervical lordosis, a thoracic or mid-back kyphosis, which is this curvature, and a lumbar lordosis, which is this curvature, and I'll be referring to those terms. Scoliosis is abnormal curvature of the spine in the frontal plane. Kyphosis, on the other hand, is abnormal roundness of the back when looking at the patient from the side. We call this a sagittal plane deformity. Most of you who have scoliosis will have heard that my curve is 50. Some people say 50%, but actually it's 50 degrees. And the way we determine this is by drawing lines and measuring the angulation of the curve and representing it with a number, in this case, 55 degrees. So this is a 55-degree scoliosis. The kinds of treatments that we offer patients with spinal deformity range from very minimally invasive or non-invasive, such as braces, to very complex procedures in an attempt to straighten out very severe scoliosis in this technique using implants as pictured. We should all remember, though, that many times degenerative conditions can cause abnormal curvatures in the spine. For example, a cervical condition, which causes reversal of the normal cervical lordosis, compressing the spinal cord. Not only was it important to decompress the spinal cord here, but to also reverse the abnormal curvature. Dr. Johnson and I are working on ways to recreate cervical lordosis in novel fashions, and we're going to publish on that soon. I'd like to briefly talk about adult scoliosis. Adult scoliosis presents as a curve that's stiff, decompensated, kyphotic, and degenerated. And unfortunately, as we get older, our spine starts to dry out. And as it dries out, it becomes much less flexible. And therefore, adult scoliosis is a much more difficult thing to deal with than it is in kids. What are the indications for treatment? Progressive deformity, curves that go from 40 to 50 to 60 degrees. Pain is the most common presentation of a patient with adult deformity. Deterioration of pulmonary function. People always come up to me and say, if I don't have the scoliosis fixed, I'm not going to be able to breathe or my heart's going to stop. That rarely happens. That's a myth. Cosmesis. We don't usually offer patients surgery just because they have a raise or a hump or an abnormality or their pants don't fit right. We usually reserve this for very serious things. Adult spinal deformity is once again different than that's found in children. It's difficult to document progression in adults. It's more difficult to isolate the pain generators because there are many vertebrae that are involved. It's very difficult to say this one hurts or this one hurts. Pulmonary deterioration, which makes the patient sick, may be due to what we call comorbidities, such as heart disease, lung disease, and commonly smoking. Mercifully, smoking is less common in our culture, so we don't worry about that. And of course, there's a superimposition of secondary gain factors. We don't have to go in. Such things as litigation will impact the ultimate outcome of certain types of surgeries that we do on any type of spine, straight or crooked. The surgical complication rate is higher for these types of procedures. I'll be very frank about that. So how do we start to treat patients? We treat their pain, anti-inflammatories, a short course of narcotics. We treat them just like we do any spinal problem. Physical therapy is very helpful, and you heard that a lot about physical therapy this morning, including modalities, endurance, strengthening. Bracing is sometimes used just to alleviate the short-term symptoms. And we commonly use injections, especially patients who have superimposition of narrowing of their spine or spinal stenosis, with scoliosis. And of course, we try to counsel the patients to what to expect after their treatment. Expectation therapy is very important in any type of spine surgery because, as Dr. Bray said, we're trying to improve you. We're not trying to make you perfect. These are some of the complications of the types of things that we do for adult scoliosis. And sometimes the complication rate can be very high, reasonably high. And therefore, only certain types of patients are selected for this type of intervention. But in the right patient, under the right circumstances, and when the surgery is done correctly, the results can be very good. We would expect a 69 to 95% improvement in pain relief with a scoliosis operation, and correction 30-40%, and also improvement in psychological component. We usually tell the patients, though, that they still may have pain, and they still may have pain every day, but they'll be much more functional with their symptoms. Most of what we do when we treat scoliosis is based on hard science. This is not stuff that's anecdotal or made up. This study, which is the landmark study from what we call the Journal of Bone and Joint Surgery, which is our major journal, evaluated 219 patients who had backaches due to scoliosis and found that it was as common as in the general population. For upper back or thoracic curves that were greater than 50 to 80 degrees, we found that they will continue to increase in adulthood. So in other words, if your curve is greater than 50 degrees, the chances are that as you get older, it's going to get bigger. Lumbar curves with the same frequency. And in conclusion, curves greater than 50 degrees have a relative indication for surgery. So the indications for surgery in adult scoliosis are thoracic curves greater than 50 degrees with documented progression. Thoracic curves greater than 50 degrees with chronic pain and who have failed conservative therapy. We always do conservative therapy first. Lumbar curves with back or leg pain, which we call radicular symptoms. And all curves that are greater than 50 degrees, cosmetically unacceptable, with a high probability of progression. All three of those components, not any one. As I told you, the spine gets dried out as you get older. That just happens to all of us. And that also has an implication in sagittal plane and deformity and scoliosis. Because as the discs start to dry out, the spine will increasingly have a posture of being more tilted forward. And so not only do we need to assess the curvature, but commonly there will be spinal stenosis or narrowing of the canal. There may be what we call spondylolisthesis or slipping of one vertebrae on the other. That's what this is. We can have cysts caused by degeneration, which may be pressing on the nerve. And all of these things need to be taken into consideration during the treatment of the curvature. Now, most of you have heard the term Harrington instrumentation. I have patients come in all the time. This is a Harrington rod. And you can see one of the downsides of this old instrumentation. Here's the rods are broken. This wasn't a very secure fixation. And in many times, the patients failed. I always, in every lecture I ever give, show this picture of my kid's broken arm. I just have very high affection for him. But the point I'm trying to make is that the instrumentation, the implants, the screws, the rods we use are just a cast. They hold things in place until the bone that we transplant onto the spine can heal. That's the fusion. The hardware is not the fusion. It's the bone that we transplant. That's the fusion. Now we have modern instrumentation systems that have wires, hooks, screws, and we're able to correct these large deformities and leave the patient with excellent balance with their heads above their pelvis in both the frontal and the side view or sagittal plane. Sometimes we're always allowed, but sometimes what we can do is we can use short instrumentation to correct curves, which is another technique to save distal lumbar levels. We know, for example, that the less levels you fuse, the less chance that a patient will subsequently have low back pain. I would just like to talk briefly about sagittal plane deformities. And these are the deformities where somebody is bent over. And if you drop a plumb line from their head, the plumb line will land much anterior to their legs. Now, any of you have tried to walk like that, bent over, know that that is a very uncomfortable position to be in. It requires a lot of energy. It usually induces low back, buttock, and leg pain. And in many cases, we call the constellation of those symptoms flat back syndrome. Sagittal plane problems are more prevalent in adults due to disc degeneration and what we call iatrogenic flat back. Iatrogenic flat back is a situation where a fusion has been done on a lumbar spine, and it's been done in such a way that the normal curvature of the spine has been taken out. So that essentially what happens is the patient walks pitched forward because of it. It requires much more extensive surgery to correct than a virgin back or a back who's never had surgery that has low back pain. And once again, I'm showing this slide of a degenerated segment, which turns out to cause significant loss of what we call lumbar lordosis in this patient. So the patient is functionally tilted forward. And the way we deal with that is commonly to do an operation through the front and the back of the spine to make the spine have a better contour. And in that sense, the patient can now walk upright, which improves their function and their pain. But these types of problems are caused by other things. Harrington instrumentation commonly tilted the patient forward because it was what we call distraction instrumentation. In other words, it distracted the spine. Certain types of traumatic injuries can also tilt the patient forward. And in this patient, the patient has had multiple operations, which has left him in a forward decompensated or forward tilted state. These types of situations require extensive surgery to correct. In the Harrington situation, the patient needed what we call osteotomies, or breaking of the fusion mass, so that ultimately the spine could be realigned. This woman came in basically walking forward, shuffling forward, and at the end of her treatment, she was standing upright and erect, which had significant positive impact on her symptoms. And finally, I'd just like to show an example. This particular pathology is called ankylosing spondylitis, and in this, which hopefully none of you have, the patient's whole spine fuses due to an inflammatory arthritis type of situation, leaving him with his head fixed in this position. He was a welder for one of the jet aircraft companies, and his head is fixed in this position. He cannot move. He's looking down at the ground, and he had been for almost 30 years working on the jet assembly line. You can see on his plain x-ray that he plumb lines well ahead or in front of his body. So not only is his head tilted forward, but he's tilted forward. So what was done with this gentleman is we did osteotomies in both his neck and his low back. This type of osteotomy means to crack the fusion mass. Resulted in much better sagittal alignment of the patient. In other words, he plumb lines now. I hope there's a plumb line here. Oh, there you go. He plumb lines now right through the center of his pelvis and is walking upright. We also did an osteotomy on his neck. You can see what happens in the osteotomy. The spine here is cracked. You see this a break in the spine? We do that on purpose in both the lumbar and the cervical spine to make him stand up straight. And this is the end result. This type of thing results in significant improvement to the patient in terms of function. And this was not even a painful condition. It was just a function and a state of life. If you would like to get any more information about major reconstruction of the spine, scoliosis, I have a website, espine.com, and also the Cedars Sinai Institute website is very good as a resource. And I thank you for your attention.